Sure. So thank you for the opportunity, and I'll be talking about Browns and followed by a few slides on the MOBIUS. Uh, Browns is something which is not so uncommon, but can be rather difficult to manage. The key findings would be deficiency in elevation and adduction, some deficiency in the midline, minimal or no deficiency in the abducted position, and a V pattern with divergence in upcase. The key investigation to do is to test for the tightness of the superior oblique, which would be tight, and you may not have a superior oblique overaction. But along with that, rarely you may see a significant downshoot in adduction, a widening of the palpable fissure on adduction, an anomalous head posture because the patient will have the head turn onto the same side so that there can be vertical alignment in the opposite gaze. Again, associated with hypotropia in the primary position. In acquired cases, you may have some amount of trochlear tenderness. You can have it divided as mild, moderate, and severe. Mild often may not get presented early. It is just a restricted elevation in adduction. For the moderate cases, there is, along with the restricted elevation and adduction, a downshoot on adduction. So on adducted position, the eye is hypotropic, but no hypotropia in primary position. And in severe cases, you may even have a hypotropia in the primary position. Jimpolsky also added a Brown's plus in which you could have a superior oblique overaction also, so you would have significant hypotropia in adducted and depression. So here you can see in this patient, there is straight up, there is a limitation of elevation. Here is not so significant, a significant limitation of elevation and adduction. Along with that, what you would be seeing is a kind of Y pattern. So as the eye goes up, if you significantly attempt to elevate it, the eye kind of swings out like a Y pattern. So that's where the discrepancy starts. If there is a superior oblique overaction, you're expecting an A pattern, but the patient looking up, the eye moves out a kind of Y pattern. So that's when you start thinking. In the presence of a superior oblique overaction, you would see a significant amount of torsion in the fundus. So Brown's plus would be diagnosed accordingly. You have a lot of differentials initially, especially if you don't understand the eye movements at that time. You can have a true inferior oblique palsy, extremely rare as an isolated inferior oblique palsy, but not uncommon. The most important finding would be that the force duction test for superior oblique will be negative, and you are going to have an A pattern present. So presence of an A pattern, and of course the FDT would help us. You could have sometimes a primary superior oblique overactions, which may be very severe. So you may have the antagonist into inferior oblique not acting not so well, so slight underaction, but again an FD force duction test helps. The other differentials could be an monocular elevation deficit, blowout fractures with inferior rectus, tight inferior rectus, and the eye is not able to go up. CFUMs, although they are very rare, it's fairly easy to differentiate them because of the other findings that are there. Congenital Browns, the most commonly what you see, the etiologies can be a short anterior tendon sheath, a normal but an inelastic tendon. Basically, the telescoping mechanism through which the superior oblique acts is not there, or there may be attachments here between the movement of the tendon with the sheath along with that. In acquired cases around the trochlea, you may have trauma, post-surgery, as was shown by Dr. Ankur, where you do a tuck of the superior oblique, you can actually generate or create a Brown syndrome, and of course inflammation. So not uncommon to see patients presenting with an acquired Brown. So this was a case of a patient who presented with an acquired hypotropia, and you can see the severe limitation of elevation and adduction, the hypotropia and adduction, not so significant hypotropia and primary gaze. So this was a patient of an acquired Browns. On imaging, you could see that there was a bulky superior oblique with a cyst, which turned out to be a cysticercosis. The patient improved significantly on medical management. So non-surgical interventions, more often than not, many of them would spontaneously improve. You can ask them to give some elevation exercises if they are recent acquired. Steroids injected locally in the trochlear area or oral, and of course treat the underlying cause if it's because of a systemic inflammatory disease. Indications of surgery would be a severe case of threatening binocularity in amblyopia, which would really be an absolute indication and you would want to go in for surgery, but which would occur in primary position hypotropia as a patient having significant anomalous head posture or unacceptable downshoots in adduction. The aim would be to correct the hypotropia in primary position and reduce the downshoots and expand the binocular diplopia free field. The possible options would be a posterior tenectomy, as so talked about, but really it does not relieve the browns per se. It just removes the posterior fibers. But if you have a tight superior oblique, you're not going to be able to relieve that. The other options discussed are superior oblique tenotomies or free tenectomies, which unfortunately should not be done because they often will result almost two-thirds patients with an SO palsy kind of a condition, and subsequently, although people have described a simultaneous IO recession also, but that would not really be acceptable. Superior oblique recessions were initially done, but because they kind of, after surgery, they kind of collapse the insertion and you lose the posterior fan-shaped insertion, which is the beauty of the superior oblique tendon. That's why superior oblique recessions were given away. Sir has modified that and he does the loop tenotomy we just saw. So, however, the downside would be to an extent of the collapse. The other option is to perform the surgeries a little away from the insertion. So all the other surgeries, the Z tenotomy or the split tendon lengthening, are a little away from the insertion, and you can lengthen the tendon accordingly. So you can do a split tendon lengthening. Wrights described the silicon band expander, which lengthened the tendon. Invariably, the problems of surgery on the nasal side can be that there can be fibrosis around the band or any other surgery that you do. So it's important you approach temporally. The Knapp's chicken suture or a suture tenopexy is probably one of the most favored now, and I prefer that to any other surgery. It can be done adjustable intraoperatively, and you can do the FTT accordingly. So this was a case of a Wright-Brown syndrome. You can see the hypotropia here, the characteristic face turn, and in this patient, we had done a spacer elongation, a silicon band, and you can see, although there is some limitation of elevation still, but you don't want a superior oblique palsy significantly developing, and that's how your endpoint should be. Slightly tight FDT may remain intraoperatively when you are doing the adjustable. This was another case of a Wright-Browns. You can see the severe hypotropia in primary position. And this patient was given amblyopia therapy but was not improving, so we did surgery and subsequently continued the amblyopia therapy. In this patient, we did the suture lengthening or the suture tenopexy to improve. And again, you can see there is a limitation of elevation and adduction, but you don't want a superior oblique underaction. You have good primary gaze alignment, and the patient's face turn improved. A quick couple of slides on the MOBIUS, a very uncommon condition. I personally have not seen more than 5 or 6 of such cases. And the most common things that you will see is a bilateral 6-nerve palsy with a large angle esotropia, which is the most important thing you would want to correct for. And of course, associated other things. The other important thing that you must know in these patients is they have a dry eye kind of a condition, and they would often suffer with epithelial defects and other associated problems. Exposure keratopathy, because they are not able to close their eyes adequately. So you need to always look on their corneas and probably manage the recurrent dry eye or erosions that they are getting. They have significant refractive error problems. They need amblyopia therapy and of course correction of associated lid anomalies, including an entropion. So goals would be to align in primary gaze essentially and increase the area of binocular visual field. The challenges, of course, are measurement and difficult anesthesia, aplasia or hypoplasia of the extraocular muscles, which again can create a problem when you are operating them. You need to do a force duction test for the medial rectus. If it's positive, you need to do an MR recession, often tri-adjustable, although it may be difficult because the muscles are rather fibrotic, with a vertical rectus transposition. If the FDT is free, you can just get away as a first surgery as a VRT, and residuals can be managed with botulinum toxin. So this was just to show you the one case. Preoperatively, we did a left medial rectus recession with adjustable sutures with a superior rectus transposition and posterior fixation suture. We just operated the left eye. The patient had good primary gaze alignment, and that's how we left the patient. He was happy, diplopia free in straight gaze. Thank you very much for the